Hi, I'll be presenting on hemorrhagic stroke secondary to hypertension emergency. In hypertension emergency, you'll see a sudden increase in your blood pressure, systolic blood pressure above 220 mmHg, diastolic blood pressure above 120 mmHg. As a result, there will be a target organ dysfunction or damage, such as intracranial hemorrhage, acute myocardial infarction, or acute left ventricular dysfunction with pulmonary edema. This is a short video to show what high blood pressure does to your endothelial cells.
It's a serious problem for the blood vessels because it causes wear and tear on the endothelial cells that line the inside of the blood vessels. Just like a garden hose that's always under higher pressure, in the long term, blood vessels can develop tiny cracks and tears that can lead to serious problems, like myocardial infarctions, aneurysms, and strokes.
Moving on, here's our patient risk factor. So patient's a type 1 diabetes mellitus. He's a smoker of 40 packets per year for 25 years. He's a social drinker. He has high BMI of 54.1. He has been taking NSAIDs for his gout pain. Adding on to his risk factor for hypertension, he's also at risk for stroke. As he's a 50-year-old male, his brother had passed away due to heart attack. He has hypertension, hyperlipidemia, and obstructive sleep apnea. So a patient presented with a clinical manifestation of blood pressure 245 over 122 mmHg. He's been complaining of recent blurred vision, 3 episodes of right-sided headache, and vomiting for the past 2 days. Here's his lab results. We can see that he has electrolyte imbalance due to uncontrolled diabetes mellitus. His ABG shows that he has uncompensatory respiratory acidosis with hypoxemia and hypoxia. And here we can see that he has hyperlipidemia. And we can also see that he has kidney damage. This is further evidenced by the fact that he has not passed urine since the onset of the condition at 8 a.m. IDC was inserted. We can see residual urine, 50 ml of red-tinged scarlet urine. Chest X-ray was done, and we can see that he has left ventricular dysfunction with right atrial enlargement. This could be due to his hypertension. And CT brain was done. We could see that there is an intracerebral hemorrhage in the right temporal lobe. Therefore, patient has hemorrhagic stroke. So in hemorrhagic stroke, hypertension is usually the main reason that causes rupture of these vessels. Blood enters the brain tissues and cerebral ventricles, compressing adjacent tissues, causing blood vessel spasms and cerebral edema. Blood in the ventricles irritates the meninges and brain tissues, causing inflammatory reaction and impairing absorption and circulation of cerebral spinal fluid. So pressure on the brain tissue from intracranial pressure can lead to coma and death. Here's a short video to show on hemorrhagic stroke.
Well, a hemorrhagic stroke is essentially when one of your blood vessels in your brain sort of springs a leak and begins to sort of leak blood out of the vessel and into the skull cavity. So that's bad for 2 reasons. I mean, 1, you're losing blood from within your cerebral circulation. And I'll show you on our friend here, if you start bleeding into your cranium, that blood leaking out of your vessels is going to take up room, right? I mean, your cranium is a closed space, so your blood has nowhere to go. So if you start bleeding into this closed cranium space, you're going to increase pressure in there and you're going to start to actually compress your brain. And another thing to think about, all of that blood leaking out of the vessel is blood obviously not continuing through the vessel to downstream vessels that serve downstream parts of the brain. So you'll start to have brain tissue die off in that distribution. And it gets even worse. So you see all this blood leaking out onto this underside surface of the brain. It turns out that blood contacting the outside of blood vessels irritates those blood vessels. So when these vessels feel all this blood, they start to get irritated and start to clamp down a bit.
So then moving on, we can see that he also has bleeding, and it's possible that this bleeding was further affected due to the side effect of NSAID. Here we can see the reason for the evidence for hemorrhagic stroke. On examination, patient presented with drowsy, he has GCS7, left-sided facial weakness, and unable to communicate. He also has paralysis and loss of sensation on the left side of his body. Left upper and lower extremity rated as 1/5, visual impairment for both eyes. Here's a picture to show you which part of the brain is responsible for what function. As patient had right hemorrhagic stroke, all of his manifestation is shown on the left side of his body. This is patient's distress.
Hi, I'm Cindy. I'll continue to talk about the immediate management plan specifically for each distress. Mr. James Kong is drowsy and only responded to pain stimuli. GCS7 with E2, V1, and 4. In this case, as Mr. James Kong has hemorrhagic stroke, we will perform neurological assessment frequently. The assessment includes level of consciousness using Glasgow Coma skills, orientation by asking place, person, and time, motor function to assess how sure he is and whether he can obey to command, and also pupillary response assessing pupil size, reaction, and equalness of both eyes. If GCS decreases, we need to assess ABCD and start correcting it. So what is ABCD? A stands for airway, B is breathing, C is circulation, and D is for disabilities. So according to the ATLS, Advanced Trauma Life Support, patients with GCS scores 8 or less require prompt intubation. As Mr. James Kong GCS is 7, which is lower than 8, we will need to intubate him using an endotracheal tube through the mouth, then into the airway to maintain short-term airway patency. Other than that, Mr. James Kong also has hypoxia, which also requires intubation. And Mr. James Kong's SpO2 level is 90%. His ABG result is uncompensated respiratory acidosis with hypoxia and hypoxemia. Our immediate management is use a mechanical ventilator such as PEEP, positive and expiratory pressure, to open collapse alveoli by supporting organ function. So next. For the distress of high blood pressure, we will need to do the hemodynamic monitoring hourly to measure the blood pressure inside the veins, heart, and arteries. Non-invasive monitoring is achieved by blood pressure reading from manual calf pressure, heart rate from ECG, temperature, respiration rate, and pulse oximetry. As Mr. James Kong's blood pressure is 245/122, we need to lower down the blood pressure by using nicardipine. That will mention that later under the pharmacological section. Now, we need to reduce the blood pressure by 25% in the first hour, which is around 180/90, and reduce to 160/100 over 6 hours. Then gradual reduction to normal over a period of days. The reason why we need to lower the pressure gradually is because lowering pressure too rapidly can trigger transient ischemic attack or stroke. Avoiding over-aggressive correction is particularly important in patients with chronic hypertension because their end organs adapt to chronically elevated blood pressures. Patients may be at risk of harm from overcorrection or over-normalization of blood pressure. So next is the distress in patients with low blood pressure, low red blood cells, and low hemoglobin. In this case, we will provide blood transfusion to replace the lost component of blood. That will also explain that further on the pharmacological section. So next is the distress of intracerebral hemorrhage in the right temporal lobe and also right-sided headache for past 2 days. So there might be an increase in intracranial pressure for the patient complaining of the headache. Therefore, external ventricular drain, EVD, will be used to relieve elevated intracranial pressure. We would suggest craniotomy, which is a surgical removal of part of the bone from the skull to expose the brain. The EVD catheter is most frequently placed by way of the twist drill craniotomy, placed at Crotchet's point, a location in the frontal bone of skull, with the goal of placing the catheter tip in the frontal horn of the lateral ventricle or in the third ventricle to remove excess cerebrospinal fluid, but in this case, we are removing excess blood in the brain as patient having hemorrhagic stroke. EVD can be used to monitor ICP, which is intracranial pressure. We need to ensure the ICP is within the normal range, which is 0 to 15 mmHg. Documentation hourly is needed, such as level of blood in the burette, or whether dressing is dry and intact. Elevated head of bed, 15 to 30 degrees to provide drainage, and the laser level device should be in line with the patient foramen of Monro. Too far above FOM, the foramen of Monro will lead to falsely low ICP and insufficient drainage. Too far below the FOM will lead to falsely high ICP and excessive drainage. Besides that, we also need to suggest mannitol for Mr. James Kong to reduce increased intracranial pressure. That will explain the medication furthermore later on. So we also need to monitor for seizure. Why? Because there's a risk of getting a seizure in a post-stroke patient, which is called post-stroke seizure. Accumulation of intracellular calcium and sodium may result in depolarization of the transmembrane potential and other calcium-mediated effects. This local ionic shift may lower the seizure threshold. We need to monitor if seizure occur and stand by phenytoin if seizures happen. So next, I'll move on to nursing care plan. We have actual nursing diagnosis and also potential nursing diagnosis. I will pick the most top 4 important, which is impaired gas exchange related to altered oxygen supply, risk for fall related to generalized weakness, impaired skin integrity related to partially immobilization, risk of infection related to external ventricular drains. So next. Impaired gases exchange related to altered oxygen supply as evidenced by patient objective data, respiration rate 22 breath per minute, SpO2 90%, ABG is uncompensated respiratory acidosis with hypoxia and hypoxemia. Subjective data is slight shortness of breath on exertion. So we come up with the intervention, which is we need to assess skin color for development of cyanosis, especially circumoral cyanosis. Why we need to assess the skin color is lack of oxygen delivery to the tissue will result in cyanosis. Cyanosis need to be treated immediately as it is a late development in hypoxia. Next, we need to assess patient's ability to cough up secretion. Take note of the quantity, color, and consistency of the sputum. Retained secretion will weaken the gases exchange. If the patient is unable to cough up the secretion, we will need to provide suctioning 4 hourly. Suctioning clears secretion that obstruct the airway, resulting in improved oxygenation as patient is sedated. We also need to assess for changes in orientation and behavior. Restlessness is an early sign of hypoxia. Mentation gets worse as hypoxia increases due to lack of blood supply to the brain. Next. Okay, we can also prop up the head of bed to 15 to 30 degrees to allow better lungs expansion. And we cannot prop the patient any more higher because it is contraindicated to the EVD. We also can place the patient on continuous pulse oximetry to monitor the oxygenation for patient and need to be maintained at 95% or above. We also need to repeat arterial blood gas test every 12 hours to provide information on how well the lungs, heart, and kidney are working. Next is risk for infection related to external ventricular drains as evidenced by patient had went through craniotomy. So we come up with the intervention that we need to monitor signs and symptoms such as redness, swelling, exudate, or pain at the incision site. Redness, swelling, exudate, or pain are the signs and symptoms of infection. Immediate intervention is required to prevent deterioration of the incision site. And the entire system needs to be changed using sterile technique when it becomes soiled or loose. The cerebrospinal fluid leakage, wet the dressing poses an infection risk. The drainage bag should be changed when it is 3/4 full. Too much weight could disrupt drainage. And we also need to ensure the integrity of the entire EVD system must be checked at a minimum of every 4 hours. Any damage or disconnection of any components report as an emergency. Next. Monitor any cloudiness or debris in the burette. Cloudiness or debris indicate infection and should be reported to the neurological team. Neurological and vital signs should be observed hourly. If CSF drains, in this case, we need to monitor the blood at high pressure will cause under drainage and lead to raise in ICP. Signs of which include reduced level of consciousness indicated by decline in GCS, changes in pupil signs and equality. Lastly, we need to ensure patients maintain regular bowel habits by using stool softener as patient is sedated. Straining to pass physics can increase the intraventricular pressure.
Hi, I'm Dad. So now we'll continue with our last two nursing care plan. The first one will be risk for impaired skin integrity related to partially immobilization as evident by patient objective data. Left upper and lower extremity rate as 1/5. Patient is obese and the paralysis and lost sensation to the left side of the body. So our first intervention is check on bony prominence such as the sacrum, trochanter, scapula, elbows, heels, inner and outer malleolus, inner and outer knees, and the back of the head. These specific areas where the skin is stretched are at high risk for skin breakdown as a result of compression of the skin capillaries between the hard surface and the bone. The next one, we use pillow or foam wedges to keep bony prominence from direct contact with each other. Keep pillows under the heels to raise off bed. These measures reduce the shearing forces on the skin. We also can assess for fecal incontinence because stool may contain enzymes that cause the skin breakdown. Use diapers will hasten the skin breakdown. Okay, next is assess the skin integrity using Braden scale every shift or as per hospital protocol. Assessment should be every 24 to 48 hours or sooner if the patient condition changes. Turning patient to hourly with elevated head of the bed 15 to 30 degrees. Turn every 2 hours is the key to prevent breakdown. Assess for edema, skin tighten over edematous tissue are at risk for impairment. Okay, so our last nursing care plan is risk for fall related to generalized weakness as evident by patient objective data. Left upper and lower extremity rate at 1/5. Visual impairment for both eye, drowsiness, GCS7 with E2, V1, and M4. Paralysis and lost sensation to the left side of the body, and also subjective data, which is complaint of recent blur vision. Okay, so what we can do is assess patient for factors known to increase fall risk, such as history of fall, mental status changes, and sensory deficits, to know the intervention that will be established. Okay, so next one, we put the cot side up at all time. Patients who are disoriented or confused have been known to climb over the cot side and fall. Instruct the patient to call for assistance when moving to prevent the patient from falling from the bed. Place items used by the patient within reach. Such to stretching to get items from bedside tables that are out of reach can disrupt patient balance and contribute to falls. We also can put patient on fall risk tag and fall risk sideboard. This one will let other staff know that patient is on high fall risk. Okay, so these are some medical management, like some medication we can administer to the patient. Okay, so now we continue with step 1 medication critique. we will start with two medications, which is diclofenac and aspirin. Diclofenac is given for gout pain, and aspirin is for cerebrovascular accident. Patient is having hemorrhage stroke, so diclofenac and aspirin is not recommended because they both NSAID, and NSAID medication can lead to poor platelet adhesion and aggregation, which increase the bleeding time. And furthermore, by taking aspirin, it will prolong the prothrombin time, which is the time to form the blood clot, and also aspirin can trigger the asthmatic symptom. Okay, next is esmolol. Esmolol is the antihypertensive will be given to treat patient hypertensive emergency. These medications should be omitted because esmolol is a beta blocker. Beta blocker are not recommended for patients with bronchospastic conditions. Patient is having with the past medical history of childhood asthma, and also can cause hypoglycemia or mask the hypoglycemia signs and symptoms. Next is simvastatin. Simvastatin given to treat patient hyperlipidemia due to the lab result. This medication can be administered as ordered because the dosage and the timing 10 mg POON are appropriate to treat patient condition which is hyperlipidemia. Okay, next is the Novolin N and Novolin R. Novolin N and R are used for diabetes management. For these two medications, I think there should be a dosage adjustment because according to patient weight and present height BGM, I changed the dosage from 2 unit to 23 unit because the recommended dosage for this medication is 0.4 to 0.5 unit per kg per day plus 10% increase in dose, which is for patient high BGM. Okay, so this is how I get the final dosage for this patient, which is 23 unit per time, because according to the calculation, right, patient weight will time with 0.5, which is the dosage. So I will have 163.8 times 0.5, so I will get 82 unit per day in total. So patient given 2 types of insulin, and each time will be administered twice. So in total, we got 4 times administered. So that I will take 82 divide 4, so which is so I will get 21 unit plus 10% increased dose, which is 2.1 units. So I will round up, so I get 23 unit per time. Okay, next are some additional medications for the patient. Just now when I withdraw esmolol, so I will replace with nicardipine. This medication will be given also for patient with hypertensive emergency. And about the dosage, I will initiate 5 mg per hour, titrate by 2.5 milligram per hour at 5 to 10 minute interval. Okay. Next medication is mannitol. Patient with hemorrhagic stroke may have increased intracranial pressure. So giving mannitol can have to reduce the ICP. So the dosage will be 0.25 to 1 gram per kg per dose. May repeat every 6 to 8 hours as needed. So the next medication is salbutamol. Salbutamol, because patient has the history of childhood asthma, so in case of the condition getting worse, he may experience some asthmatic symptom. So that's the reason why I recommend salbutamol. Salbutamol will be given for the treatment of asthma and the prevention of bronchospasm. So the dosage I can give like 500 mcg or 8 mcg per kg once, and may repeat every 3 to 4 hours as needed. So the next medication is phenytoin. This one can be given intravenous. The indication for this medication is the post-traumatic seizure prophylaxis. Patient with hemorrhagic stroke may experience stroke later, so that's the reason why I recommend this medication. About the dosage, I got 2 types of dose, is loading dose and maintenance dose. About the loading dose, right, we'll start with 17 to 20 mg per kg at a rate of less than 50 mg per minute. Maximum dose for this is 2 gram. And the maintenance dose, I will give 5 mg per kg per day divided every 8 hours. So the last one will be red blood cell transfusion intravenous. The reason why I recommend this medication is because according to patient lab result, RBC and the hemoglobin level is low. So I recommend the dosage of 3 units of red blood cell, because 1 unit of red blood cells should increase the hemoglobin level by 1 gram per dl.
Okay, now I will introduce the extend case scenario. Ms. James Kong continued to receive hospital treatment based on the doctor's recommendation. In the cubicle, the registered nurse saw that he had short list of breath and his leg was swollen. In addition, when the nurse checked the IO chart, she noticed that the patient's urine output decreased. The nurse gently pressed patient's leg and noticed there is 4 mm deep pit and a few seconds to rebound. For patient's vital signs, her blood pressure is 160 over 120, pulse rate is 85, temperature is 37, respiration rate is 20, and SpO2 is 96%. On exam, her GFR is 14, her urea is 36, her serum creatinine is 2 and potassium is 6.5. The GFR glomerular filtration rate is a test used to check how well the kidney are working. It estimates how much blood passes through the glomeruli each minute, and GFR below 15 means renal failure. For serum creatinine, it used to evaluate the renal function. In acute renal failure, serum creatinine level rapidly increased within 24 to 48 hours and peak within 5 to 10 days. For potassium, when kidney fail, For GFR, glomerular filtration rate is a test used to check how well the kidney are working. It estimates how much blood passes through the glomeruli each minute, and GFR below 15 means renal failure. For serum creatinine, it is used to evaluate the renal function. In acute renal failure, serum creatinine level rapidly increased within 24 to 48 hours and peak within 5 to 10 days. For potassium, when the kidney fail, they can no longer remove excess potassium, so the level will build up in the body. There are 3 phases of acute renal failure. First phase, initiation phase, begin with initial events such as hemorrhage and end when tubular injury occurs. The second phase is maintenance phase. It's characterized by significant in GFR decrease and tubular necrosis. The GFR drop may cause oliguria, and the kidney cannot efficiently eliminate metabolic waste. This patient, her GFR drop and his urine decrease. The third phase is recovery phase, characterized by process of tubular cell repair, regeneration, and return of GFR to normal or pre-acute renal failure level. And diuresis occurs and return salt, water, and solutes are excreted. Renal function improves rapidly during first 5 to 25 days and continue to improve up to 1 year. The immediate management plan. Monitor patient vital signs hourly. Because hypertension, tachycardia, and tachypnea may indicate excess fluid volume. Ensure strict intake and output record to assess fluid status. Provide skin care to prevent skin breakdown due to disposition or irritation toxin in the patient's skin. Also provide psychological support because there are many complications of acute renal failure. This may stress our patient and we have to provide the emotional support.
Okay, I am Katrina and I will be continuing with medication for acute renal failure. These 3 medications will be targeting hyperkalemia for acute renal failure. These include calcium gluconate, dextrose 50%, and insulin, sodium polystyrene sulfonate. So which medication to choose and why? I will be comparing these 3 drugs and then choosing one at the end accordingly. So first, calcium gluconate. The pros is that there is an onset of action which is very rapid at 1 to 2 minutes, and we can expect a decrease in potassium level of 0.5 to 1.5 MEq per liter. Cons is that we have to use this in conjunction for patients with severe hyperkalemia, as acute rises in serum calcium level may result in life-threatening cardiac arrhythmia. Next, dextrose 50% and insulin. This combination of medication can reliably lower the serum potassium level by 1 mmol per liter within 10 to 20 minutes, and the effect can last about 4 to 6 hours. Cons, this therapy is associated with significant hypoglycemia. Sodium polystyrene sulfonate is appropriate to use for patients with diabetes, while the cons is that it shouldn't be used as an emergency treatment for life-threatening hyperkalemia due to the delayed onset of action. So our final decision is to be using calcium gluconate because of the rapid onset of action of 1 to 2 minutes. So calcium gluconate plays a role in regulating storage and releasing of neurotransmitters and hormones, regulating amino acid uptake and absorption of vitamin B12, gastrin secretion, and in maintaining structural and functional integrity of cell membranes and capillaries. 3 possible side effects include hypocalcemia, extravasation, and cardiac arrest. So the nursing considerations for calcium gluconate includes first, monitoring of ECG during IV administration. This will detect for any evidence of hypocalcemia, which can be seen by the decrease of QT interval associated with inverted T wave. Next, we have to monitor for signs and symptoms of hypocalcemia, which includes stomach upset, nausea, vomiting, and constipation. Next, we have to observe for the IV site closely and carefully because extravasation may result in tissue irritation and necrosis. Next, we have to administer the drug slowly because high concentrations may cause cardiac arrest. Next, these 3 drugs will be targeting fluid retention or edema in acute renal failure. The medication include furosemide, chlorothalidone, hydrochlorothiazide. So which medication to choose and why? Again, I will be comparing these 3 drugs and then choosing one at the end. So for furosemide, pros is that there is a fast onset of action for oral and sublingual 30 to 60 minutes, and we can see a symptomatic improvement within 15 to 20 minutes. Cons that if it is given in excessive amounts, like other loop diuretics, it can lead to profound diuresis, resulting in fluid and electrolyte depletion. Next, for chlorothalidone, the pros is that it is appropriate for patients with high blood pressure and heart failure. And the pros for hydrochlorothiazide is that it increases the fractional excretion of sodium and chloride more than furosemide did in hypertensive severe renal failure patients. Cons for these 2 drugs is that it will lead to electrolyte disturbances, which include signs and symptoms such as hypokalemia, hypomagnesemia, and much more. Next is the slow onset of action with chlorothalidone at 2.6 hours and hydrochlorothiazide at 2 hours. So our final decision drug is furosemide because of the fast onset of action. So furosemide promotes diuresis by blocking tubular reabsorption of sodium and chloride in the proximal and distal tubules, as well as in the thick ascending loop of handling. This inhibition results in increased excretion of water, along with sodium, chloride, magnesium, calcium, hydrogen, and potassium ions. 3 possible side effects include hypotension, hypokalemia, and dehydration due to excessive urination. So nursing considerations for furosemide include, first, monitoring vital signs closely, especially the blood pressure, because this drug can cause acute hypertensive episodes and sudden death from cardiac arrest has been reported. Second, monitor for signs and symptoms of hyperkalemia, because this drug can cause that. Thirdly, we have to monitor the patient's IO and report any decrease or unusual increase in output, because excessive diuresis can result in dehydration and hypovolemia, circulatory collapse, and hypotension. Lastly, we have to monitor urine, blood glucose, and HbA1c closely in diabetics and patients with decompensated hepatic cirrhosis, because this drug may cause hyperglycemia. And that is all for my part. Thank you.